Hi everyone, welcome to MSP. Today we are going to talk about celiac disease. Celiac disease is a small intestinal immune mediated inflammatory disease occurring in genetically predisposed individuals, and it is caused by sensitivity to toxic component prolamins of cereal grains like gliadin in wheat, sicalin in rye, hordein in barley, and avenine in oats. Immune response results in chronic inflammatory infiltrates in epithelium and lamina propria, crypt hyperplasia and villus atrophy, and eventually leading to malabsorptive manifestation like diarrhea, steatorrhea, flatulence, weight loss, and failure to thrive in infants. Diagnostic protocol includes serology along with histological confirmation. Serological tests include IgA anti-TTG, that is tissue transglutaminase antibody, and anti-EMA, endomysial antibody. For microscopy, at least one biopsy specimen from duodenal bulb and four specimens from postbulbar duodenum should be taken. Now coming to orientation and points to be noted, let's see the histomorphological features. Before coming to that, we need to ensure certain requirements such as adequate thickness of the microsection, preferably it should be 3 to 4 micron in thickness. Villi are finger-like surface projections, whereas crypts, also known as crypts of Liverpool, are invaginations of the lining into the mucosa. IEL to be counted at the villus tips or in the upper third of the villus epithelium, and at least 500 epithelial cells in at least 5 oriented villi tips should be counted. Proper orientation indicates presence of consecutive 4 to 5 longitudinally oriented crypts over the muscularis mucosae. Points to be noted that the mucosal fragment shouldn't be considered for evaluation whenever it is taken over the submucosal Brunner glands and when there is a large reactive lymphoid follicle in the lamina propria. They can show artifactual villus flattening. Although there are various histological classification available, Ovihuber modifications of the Marsh grading is widely used. This modified Marsh grading is based on three distinct morphological features, namely intraepithelial lymphocytosis, that is aelosis, crypt hyperplasia, and villus atrophy. Aelosis, normally IELs are scattered more in the lateral edge of the villi, with decreasing in number from the villus base to the villus tip. This is called decrescendo pattern. Upper limit of normal IELs in the duodenum is up to 25 IEL per 100 enterocytes. A count between 25 to 29 is considered a borderline increase, whereas greater equal to 30 indicates a definitive increase of IEL that is also called pathological lymphocytosis. The cutoff previously considered in the modified Marsh classification was 40 IELs per 100 enterocytes. That was derived basically from older studies assessing jejunal biopsy samples. So it is best to consider greater or equal to 30 for the duodenum and greater or equal to 40 for jejunum as intraepithelial lymphocytosis. In doubtful cases where IEL is mildly elevated, CD3 immunohistochemistry can help to highlight the IELs. There may be other morphological features such as decreased enterocyte height, intracytoplasmic vacuolation, loss of brush border, and thickened subepithelial collagen, mainly in the refractory celiac disease. Crypt hyperplasia. Crypt hyperplasia suggests elongated, tortuous, and branching crypts with cytoplasmic amphotube basophilia. These regenerative changes are often associated with more than one mitosis per crypt. Villus atrophy. To measure villus to crypt, that is VC ratio, villus height and crypt depth are determined from an imaginary line at the villus and crypt junction. Normal VC ratio is 3:1 to 5:1. In modified Marsh grading, mild villus atrophy, that is 3A, refers to a VC ratio of less than 3:1 to 2:1, while marked villus atrophy, that is 3B, indicates a VC ratio of less than 1:1. Total villus atrophy, that is 3C, represents a completely flat mucosa. Modified Marsh grading describes 5 types, type 0 to type 4. Type 0 or pre-infiltrative, it shows normal mucosa with less than 30 IELs per 100 enterocytes. Type 1 or infiltrative type is characterized by only ielosis or intraepithelial lymphocytosis that is greater or equal to 30 IELs per 100 enterocytes. Type 2 or infiltrative hyperplastic type manifest ielosis and crypt hyperplasia. Type 3 or destructive lesion is characterized by ielosis, crypt hyperplasia along with villus atrophy. Depending on the degree of villus atrophy, it is again divided into 3 subgroups. 3A indicates mild atrophy, 3B marked, and 3C total villus atrophy. Type 4 or atrophic type is a rare pattern mostly encountered in refractory celiac disease. It is characterized by flat mucosa with only a few crypts and near normal IELs. Modified Marsh grading, mainly type 3A and 3B lesions, may have a high degree of inter-observer variation. Corazza and Villanasi have simplified it into 2 categories: non-atrophic grade A lesion and atrophic grade B lesion. Depending on villi, grade B is further subdivided into B1 and B2. B1 indicates presence of villi, whereas B2 suggests absence of villi. Type 4 lesion is not included in the Corazza classification.